2026 updated Green Top Guideline number 57. Reduce fetal movements. Text in red boxes are the recommendations in this guideline. Background. The perception of fetal movement starts between 16 and 24 weeks of gestation. Movements acquire regular pattern by 28 to 32 weeks. Reduced fetal movements suggest impending fetal death via placental dysfunction. The stillbirth rate in 2022 was 3.35 per 1,000 live births, using the Kodak classification. Of these, 33.9% stillbirths were unexplained and 36.3% were related to placental causes. Recent systemic analysis showed that reduced fetal movements had increased odds of stillbirth, odds ratio 3.44, and SGA, odds ratio 1.73. What are considered to be normal fetal movements during pregnancy? Advise women that they are likely to feel fetal movements from 20 weeks. Most women feel fetal movements from 18 to 20 weeks. Multiparous feel fetal movements as early as 16 weeks. Primiparous feel fetal movements later than 20 weeks. Movements plateau after 32 weeks. After 32 weeks, approximately 90% women experience either an increase or no change in the frequency and strength of fetal movements until the onset of labor. Frequency and strength of movements does not normally reduce in third trimester, although nature of fetal movement changes in late pregnancy. Presence of regular fetal movements during pregnancy is an indicator of fetal well-being. Fetal activity represents integrity of the fetal central nervous and musculoskeletal systems. Fetal movements are usually absent during fetal sleep cycles, which occur regularly throughout the day and night and usually last 20 to 40 minutes and rarely exceed 90 minutes in a healthy fetus. Advice for women about their perception of fetal movements. Advise women to be aware of fetal movements up to and including the onset of labor. Report any decrease or cessation of fetal movements to their maternity unit, especially if following an episode of sudden excessive, vigorous fetal movements. Do not attribute reduced fetal movements to a raised body mass index. Do not attribute reduced fetal movements to an anterior placenta if a change in movement occurs. Women's perception of fetal activity is influenced by a wide variety of factors mentioned in Table 1. Factors that increase perception of fetal movements. Focused attention on fetal movements. Maternal exercise, maternal anxiety, and mealtimes. Factors that decrease the perception of fetal movements. Anterior placenta, drugs such as alcohol, benzodiazepines, methadone, fetal musculoskeletal or neurological anomalies, and distraction. Factors that have unclear effect on perception of fetal movements include caffeine, glucose, corticosteroids, and raised BMI. How can fetal movements be assessed? Fetal movements can only be assessed over time by maternal perception, which is subjective, unless undergoing repeated ultrasounds. Sensitivity for recording fetal movements is 30.8% by maternal perception and 31.5% to 57.2% by ultrasound. Should fetal movements be counted routinely in a formal manner? There is insufficient evidence to recommend formal fetal movement counting using specified numbers. Women should be advised to be aware of their baby's individual pattern of movements. If women experience reduced fetal movements, they should be seen by their maternity service. The majority of evidence indicates that asking women to monitor fetal movements is not associated with increased maternal anxiety. However, it increases maternal fetal attachment. Table 2. Summary of 7 quantitative studies evaluating the impact of maternal awareness of fetal movements. Pause to read. What is the optimal care of women with reduced fetal movements? When a woman presents with reduced fetal movements, the initial goal is to exclude fetal death, which occurs in less than 1% of these instances. Subsequent to this, the aim is to exclude fetal compromise and to identify pregnancies at risk of adverse pregnancy outcome while avoiding unnecessary interventions. What should be included in the clinical history? Upon presenting with reduced fetal movements, a relevant history should be taken to assess a woman's risk factors for stillbirth and FGR. All clinicians should be aware of the association of reduced fetal movements with key risk factors for adverse pregnancy outcomes such as FGR, SGA fetus, placental insufficiency, and congenital anomalies. Table 3. Risk factors for adverse outcomes after maternal presentation with reduced fetal movements. Cigarette smoking odds ratio 2.96. Past obstetric history of SGA baby or stillbirth odds ratio 2.10. Past medical history, for example diabetes or hypertension, odds ratio 2.35. Recurrent presentation with reduced fetal movements 2 or more times, odds ratio 1.60. Odds ratio for SGA 8.04. Symphysis fundal height 10th centile odds ratio 15.43. Raised uterine artery pulsatility index in second trimester, odds ratio for SGA 5.73. If after discussion with the clinician it is clear that a woman does not have reduced fetal movements, there are no other risk factors for stillbirth and the fetal heart is present on auscultation, they can be reassured. However, if they are in the community setting and still have concerns, she should be advised to attend their maternity unit. Women noticing a reduction in fetal activity where other risk factors for stillbirth are identified should attend their maternity unit for further investigation. What should be covered in the initial clinical examination? If a woman presents with reduced fetal movements in the community setting with no facility to auscultate the fetal heart, the woman should be immediately referred to their maternity unit for auscultation. When a woman presents with reduced fetal movements in the community or hospital setting, an attempt should be made to auscultate the fetal heart using a handheld Doppler device to exclude fetal death. If the presence of a fetal heartbeat is not confirmed, then immediate referral for ultrasound assessment of fetal cardiac activity must be undertaken. Clinical assessment of a woman with reduced fetal movements should include assessment of fetal size by measuring symphysis fundal height, blood pressure, and urinalysis for proteinuria. What is the role of cardiotocography? In women with reduced fetal movements, after fetal viability has been confirmed, arrangements should be made for them to have a computerized cardiotocograph to exclude acute fetal compromise if the pregnancy is 26 plus 0 weeks of gestation or later. CTG duration, at least 20 minutes. Compared to traditional CTG interpretation, computer systems for interpretation of CTG after 26 weeks of pregnancy reduce perinatal mortality, predicting umbilical acidosis and depressed APGAR scores. Stillbirth rates after a reactive CTG were 1.9 per 1,000 births, and after a non-reactive CTG were 26 per 1,000 births. What is the role of ultrasound assessment of fetal biometry, liquor volume, and umbilical artery Doppler? Ultrasound scan assessment should be undertaken as a part of the preliminary investigations of a woman presenting with reduced fetal movements after 28 weeks of gestation, if the perception of reduced fetal movements persists despite a normal CTG, if there are any additional risk factors for FGR or stillbirth, and if an ultrasound has not been performed in the preceding 2 weeks. CTG and ultrasound should be performed within 2 hours if women reported no fetal movements, and within 12 hours if they reported reduced fetal movements. If an ultrasound assessment is deemed necessary, it should be performed at the earliest available opportunity. Ultrasound assessment should include the assessment of abdominal circumference or estimated fetal weight to detect an SGA fetus, assessment of amniotic fluid volume, and umbilical artery Doppler. Ultrasound should include assessment of fetal morphology if this has not previously been performed. Is there any role for using the biophysical profile? There is insufficient evidence to recommend a biophysical profile in all women with reduced fetal movements. The basis of a biophysical profile is the observed association between hypoxia and alterations of measures of central nervous system performance, such as fetal heart rate patterns, fetal movement, and fetal tone. Biophysical profile has a low false negative rate of 0.07%. That is, fetal death is rare in women in the presence of a normal biophysical profile. However, other small study found no difference in biophysical profile score between those with an adverse outcome and those without. Is there any role for assessment for fetomaternal hemorrhage? Fetomaternal hemorrhage is a rare cause of reduced fetal movements, less than 0.5%, but should be considered in the presence of a non-reassuring or sinusoidal CTG. If CTG is normal and there is clinical suspicion of FMH or fetal anemia, this can be assessed by Doppler velocimetry of the MCA or Kleihauer. Doppler velocimetry of the MCA has sensitivity 100%, specificity 99%. Kleihauer-Beck test has sensitivity 76 to 100%, specificity 80 to 99%. As Doppler velocimetry can be performed more promptly, this would be preferred. What actions should be taken if anomalies in fetal growth or heart rate monitoring are detected during the assessment? If anomalies are present on antenatal CTG, intervention should be discussed with a senior obstetrician, and decisions about birth should consider gestation and the degree of anomaly. Evidence of suspected acute compromise on the CTG, immediate steps should be taken to expedite birth. Lesser degrees of concern on CTG, further CTG monitoring may be instituted with a plan for frequent reassessment. If the fetus is found to be SGA or there are anomalies of umbilical artery Doppler or liquor volume, care should be in accordance with Green Top Guideline on care of SGA fetus and a growth-restricted fetus. What is the optimal surveillance method for women who have presented with reduced fetal movements in whom investigations are normal? Women should be advised about the normal physiological changes in fetal movement throughout pregnancy and actions to take if concerned. Healthcare professionals can reassure women with a single episode of reduced fetal movements that they are unlikely to have an adverse perinatal outcome. Most women, approximately 70%, who perceive a reduction in fetal movements will have a good outcome to their pregnancy, for example, above 10th centile or uncompromised baby. The commonest finding was birth to a SGA baby in 14.3% to 23% of women. There are no data to support formal fetal movement counting kick charts after women have perceived reduced fetal movements and have normal investigations. If women who have normal investigations after one presentation with reduced fetal movements have another episode of reduced fetal movements, they should be advised to contact their maternity unit for further assessment. What are the indications for intervention if investigations are normal? Where there is no objective evidence of fetal compromise, no CTG anomalies, no evidence of reduced fetal growth, oligohydramnios, or umbilical artery Doppler anomalies, women should be reassured there is no indication for expediting birth. A firm intervention study offered induction of labor for women presenting with recurrent reduced fetal movements after 37 weeks of gestation. Result was an increase in induction of labor and birth by cesarean without improving neonatal outcomes. A decision to expedite birth should be made on an individual basis in partnership with the woman. If women present with reduced fetal movements after 39 weeks of gestation, expediting birth does not appear to be associated with increased risk to mother or baby. What is the optimal care of women who present recurrently with reduced fetal movements? When a woman recurrently perceives reduced fetal movements, care should be reviewed to exclude predisposing causes. Ultrasound assessment should be undertaken as a part of investigations. Clinicians should be aware of increased risk of poor perinatal outcome in women presenting with recurrent reduced fetal movements. Women who present on 2 or more occasions with reduced fetal movements after 28 weeks are at 1.4% increased risk of stillbirth versus 0.6% with 1 episode of reduced fetal movements. 44.3% risk of FGR versus 9.8% with 1 episode of IFM, and odds ratio of 8.04 for preterm birth. Decision whether to induce labor at term in a woman who presents recurrently with reduced fetal movements when the growth, liquor volume, and CTG appear normal must be done after careful consideration by an experienced obstetrician on an individualized basis and in partnership with the woman. What is the optimal care for reduced fetal movements in a multiple pregnancy? When a woman presents with reduced fetal movements in a multiple pregnancy, care should be taken to determine the chorionicity of the twin pregnancy. According to Embrace, reduced fetal movement was noted to be a presenting symptom of twin-to-twin transfusion syndrome in monochorionic twins or fetal compromise in dichorionic twins. When a woman presents with reduced fetal movements in a multiple pregnancy, investigations to identify developing fetal compromise should be undertaken, including CTG, assessment of fetal growth, liquor volume, and umbilical artery Doppler. What is the optimal care for reduced fetal movements before 28 weeks of gestation? If a woman presents between 24 plus 0 weeks of gestation and 26 plus 0 weeks of gestation, the presence of a fetal heartbeat should be confirmed by auscultation with a Doppler handheld device and a history taken to determine other risk factors for stillbirth or early onset FGR. There is no evidence to recommend the routine use of CTG surveillance in this group. If there is clinical suspicion of FGR, consideration should be given to the need for ultrasound assessment. There is no evidence on which to recommend the routine use of ultrasound assessment in this group. If a woman presents with reduced fetal movements prior to 24 weeks of gestation, the presence of a fetal heartbeat should be confirmed by auscultation with a Doppler handheld device. If fetal movements have never been felt by 24 weeks of gestation, an anomaly scan should be performed if not already completed. Referral to a fetal medicine specialist should be considered if concerns remain. Possibility of underlying neuromuscular condition. What is the appropriate action following maternal perception of excessive fetal movements? Clinicians should be aware of an association between a single period of exaggerated or excessive fetal movements and stillbirth after 28 weeks of gestation. If women are concerned about excessive or exaggerated fetal activity after 28 weeks, fetal well-being should be assessed by CTG. If the CTG is normal, women can be reassured. CTG anomalies should be reviewed by a senior clinician. There is no indication for intervention for increased fetal movements unless there is objective evidence of fetal compromise on the CTG. Algorithm of care pathway for women with reduced fetal movements. When a woman attends with presentation of reduced fetal movements at or after 28 plus 0 weeks of gestation, take a detailed history including risk factors for stillbirth and FGR. If history does not confirm reduced fetal movements, then offer to auscultate fetal heart sounds and routine antenatal assessment. Also, give advice regarding further episodes of reduced fetal movements, and if unsure whether fetal movements are reduced, then focus on fetal movements for 2 hours. If they do not feel more than 10 movements in 2 hours, then contact healthcare provider. But if history confirms reduced fetal movements, then auscultate with handheld Doppler to confirm fetal viability. If fetal heart sounds are not present on auscultation, then perform an immediate ultrasound to exclude or diagnose intrauterine fetal death. If the ultrasound is normal, then reassure the woman and give advice regarding further episodes or reduced fetal movements. However, if ultrasound confirms intrauterine fetal death, then manage as per unit protocol. If fetal heart sound is present on auscultation, next step is to perform a CTG to exclude acute fetal compromise. If on CTG there is normal fetal heart rate pattern and perception of reduced fetal movements has resolved and there are no risk factors for stillbirth or FGR in history, then reassure and give advice regarding further episodes of reduced fetal movements. But if despite normal fetal heart rate pattern on CTG, woman continues to have reduced fetal movements or there is any risk factor for stillbirth or FGR in history, then next step is to perform an ultrasound for estimated fetal weight or amniotic fluid volume or umbilical artery Doppler. If it's normal, then reassure and give advice for further reduced fetal movements. But if abnormality is detected on scan, then manage as per unit protocol. If the CTG shows suspicious or pathological fetal heart rate pattern, then manage as per unit protocol.